Everyone. So last time we have talking about histamine, right? And we've got to know that histamine is an local hormones, right? So local hormones means there is a difference between local hormones and endocrine hormones. Endocrine, they're produced by the glands, stored also by the glands, and reach to the systemic circulation. But in case of local hormones, they are just produced locally and do not reach to the systemic circulation. And then later on, before we have gone through that histamine releases and all. It's released through two mechanisms: hypersensitivity and because of drugs. And then we've got to know where histamines are produced in the tissue, cells, and neurons. Only three. Then after that, we've moved to the the histamine receptors. We have four receptors: H1, H2, H3, and H4. We've got also to know that H1 are present in the smooth muscles, endothelium, and brain. What they will do if there is an interaction between H1 receptor and histamines will have symptomatic effect on the smooth muscles, contraction and all. Second, we have vasodilation, and third thing, we have skin itching. That is H1. H2, where it's present mainly in the gastric mucosa, it will increase, and the heart, it will increase the gastric acid as well as a direct stimulation of the heart. And then we have third H3 receptors are present in the presynaptic neuroreceptors, which will decrease the neurotransmitters, usually in the brain. And then we have H4 receptors present in the neurons and the mast cells. What they will do, they are playing an important role in the chemotaxis. Chemotaxis is nothing but migrations of the cells. Okay, coming to today's topic. Today's topic will go to know about the pharmacodynamics and the actions and therapeutic effect of the antihistamines, because there is no therapeutic effect of the histamines. Usually histamines have no actions, like preferred actions, so we need to block the histamine receptors. Mainly we'll talk about H1 receptors. Okay, so coming to the pharmacological actions of the session will be like a little bit long, but I hope you all guys will understand. So histamine exerts a powerful effect on the smooth muscles. I have a powerful effect on the smooth muscles. Smooth muscles means what? Anyone? Smooth muscles? Smooth muscles. Smooth muscles present where, lungs, yeah, GI and all. Okay, and have also an cardiac muscle stimulation. We'll do stimulation, contraction and all, increase the cardiac output. And the endothelial and nerves effect that will happen when you have pains and all, due to the neurons stimulation. So the first one that we talk about, neurons. When histamine reaches to the neurons, what will happen? In neurons, histamine is a powerful stimulant of the sensory nerves. Powerful stimulant of the sensory nerves, especially those mediating pain and itching. So because of the how will when histamine is produced in the skin and all, will have itching and we have pain, right? That is because of the powerful stimulation of the histamine at the neurons. Second thing, we have the heart. What histamine will do in the heart? First, we have the vasodilation effect, and we have in the H2 receptors will have a direct stimulation. Direct stimulation means they'll have vasodilation at the H1 receptors due to the increase of the nitric oxide. When the nitric oxide are produced or released into the endothelium and the vascular smooth muscles, vasodilation will be there, and that's why they'll have a tachycardia. Then bradycardia. Then we have a reflex bradycardia due to the tachycardia of the histamine. Then we have something called triple response of the wrist. This is a scientist who what he have done. He have injected histamine to the skin. Three responses he got. One is red spot, and that's because of what? Due to direct dilatation of the blood vessels. That's why you have got red spots. Blood will come out through the blood vessels, and that's why he had the red spot. Then he had second fall, he had flare. Flare is nothing but the pain due to the neuron stimulation. And third, we have edema. Edema due to the visceral permeability of the histamine. Then again, they have we've got to know on the neurons, then we've got to know in the cardiac, in the heart. Then third thing we have in the bronchi. Bronchi, the histamine is considered to be a bronchoconstrictor. That's why, you know, patients who will have asthma and all, one of the class of the asthma, they have mast cell stabilizers, prevent the histamine release. Okay, and then at the stomach, we have H2 receptors, which increase the gastric acidity and all. And the nose, we have three things. We have runny nose, and we have seasoning, and we have nasal congestions. Can anyone tell me why we'll have runny nose? Runny nose of the histamine due to what? Actually, you know, the histamine or local hormones and all, yeah, it will increase the production of glands. So the glands inside the nose will happen, they increase or hypersecretion from the glandular tissue. That's why they'll have the runny nose and all. Sneezing due to the neurons only, stimulation of the neuronal stimulation. Then nasal congestion, which is due to the vascular congestion associated with the vasodilation. Vasodilation will be there, fluid will be accumulated, and that's why they have accumulation. Then in the brain, H1 receptors are there in the brain and act as a like stimulant. That's why people who have H1 antagonists, they'll be sedating, right? Sedation and all because of H1 receptor. Because histamine neurons in the brain increase wakefulness and prevent the sleep by the H1 receptors. Okay. Then coming to the, like, we've got to know about the actions and all. Now we get to know about the antihistamines. We have 4 types of antagonists of the histamines. One, physiological antagonist. Can we, like, anyone tell me what is the meaning of physiological antagonist? Physiological antagonist of the drugs. Antagonism, no? So one will increase, the other will decrease. But physiological means what? 2 drugs have the same effect, different effect, but they don't act on the same receptors. For example, adrenaline. Adrenaline will do a vasoconstrictor and bronchodilator, right? Histamine will do the reverse thing, but through the histamine receptors. We will do vasodilation, and they will do the bronchoconstrictor. That is called a physiological antagonist. Okay. Then we have mast cell stabilizers, prevent the degranulation of the mast cells. Usually these medications are used in the asthma. And then we have the histamine enzymes, which is diamine oxidase. Usually it metabolizes the histamine, so there will be no actions. And then we have the 4 histamine receptor antagonists: H1, H2, H3, H4. The first generation, which is this 7 drugs: chlorpheniramine, brompheniramine, hydroxyzine, tiroladine, and dimethenidate, clemastine, and pheniramine. That are the first generation. We have two generations, first generation and second generation, but we have divided to 3 generations because of this class are just, you know, derived of this from this class, but they have like fewer advantage of this second generation. So in the first generations, what's usually, you know, like properties of first generation of antihistamines? Usually is the first medications that are antagonized the histamine. Usually they start with this. They are sedatives, means they cross the blood-brain barriers easily. They are lipophilic, so they cause sedation. So they cannot be given in anyone who is working on this, you know, and like climbing and all. They cannot be given. It's contraindicated because it causes sedation, causes sleep. Second, they have short duration. Short duration means they have to be given at least 3 to 4 times a day. And then they have also, apart from the histamine antagonist, they have antiemetic effect, they have anticholinergic effect, they have anti-adrenergic effect. So they are not just specified to the histamine release, they are non-selective. So among of these seven medications, what's difference between, what's the difference between these six? Chlorpheniramine, okay, triploidine have a slight sedation, and usually it's combined with the common colds. Usually in the cold medications and all, they'll have like 4 dual therapy, right? They'll have antibiotic, and they'll be like antihistamine, anti-tussive, and decoxins for medication, right? Usually chlorpheniramine and triploidine are combined with this medication. Okay, then hydroxyzine has a marked sedation. Hydroxyzine, they're having a marked sedation. The remaining things, they have a slight sedation, like compared to the hydroxyzine is the drug which is have a marked sedation. These are two combined. This and this are combined. Chlorpheniramine and triploidine are combined in the cold medications, and the remaining are used separately as antihistamine. Coming to these medications: diphenhydramine, cyclizine, doxylamine, hydramine, and meclizine, promethazine. These are usually used as antiemetics. For this, it's used in the drugs which are used for the colds and all. But for these medications usually combined with the medications that inhibit like nausea and vomiting. The difference between these, they have less sedation compared, they have less sedation compared to this. Except cyclizine and meclizine have a higher sedation compared to the others. But usually these medications are combined with the drugs that is used an antiemetic or anti-nausea. Then we have one alone, cyproheptadine. It's a first generation antihistamines which have anti-serotonin effect. So the off-label use of this medication is to increase the appetite. Then coming to the second generation compared to the first generation, they have a long duration of action. They don't have any other effects, and they do not slightly cross the blood-brain barriers. And what else? More selective. They don't have any antiemetic and all. They usually prescribe it alone. Okay, so apart from this is the ophthalmic antihistamines. Ophthalmic antihistamines, usually it's used in the conjunctivitis of the eyes. Okay, all they are acting the same thing. There is no off-label or extra drugs, extra use of these medications. Apart from this, azolastine, olipatidine. Azolastine, this and this have intranasal formulation. Only intranasal formulation. Okay, and then ketoconazole. This medication have an oral formulation, and apart from that, they are in the form of eye drops. Coming to the third generation. Third generation, actually it is derived from this cetirizine and then loratadine. So what's the difference between this and this? These medications are actually prodrugs. It has to be metabolized to produce the active ingredients. Okay, but what about this phenadidine? Phenadidine, actually it was a drug of the second generation, but they have removed it because of oxyphenidate. If it is taken with, it has to be metabolized, right? But if this drug is taken with the liver microsomal enzymes inhibitors, such as erythromycins, ketenophils, and graphrose and all, it will increase the secretion, it will increase the level of this drug, which leads to toxicity and leads to QT prolongation. So that's why they withdraw this medication and they give the active ingredient of this. We can then just, because it's going so much, so we'll just prevail on the contraindicated medications when it is contraindicated. First generation medications are contraindicated in the treatment of individual working in the jobs which have wakefulness. Means people who is working, it has to be awake, like driving and all. We cannot give first generation antibiotic. We can go with the second generations. Okay, and then toxicity. Usually, systemic acute toxicity will happen with this medication, especially in children. Who was taken Emitrix. Emitrix is nothing but cyclozine. This one, cyclozine. Okay, so for children who they are giving us antiemetics and all. For children who is below 6, it's not preferred to give. So we can go with serotonin antagonist because it has fewer side effects and fewer toxicity. So this medication cannot be given as an antiemetic medication in children. Okay, and then drug interactions. We have drug interaction with the first generation antihistamine drugs are contraindicated or have interaction with the anxiolytic and hypnotic drugs, such as anyone, benzodiazepines and all, because it has sedative effect. So if we are giving these medications with the hypnotic medication, it will increase the level of sedation and all, basically will go comatose. And then with the MAO inhibitors, monoamino oxidase inhibitors. Monoamino oxidase inhibitors are used as what? This enzyme is responsible for the metabolism of what? Adrenaline. So it should not be given like this, because we've got to know that the first generation medications have antiemetic and antiadrenergic effect, right? So we cannot give these medications. It will increase the anticholinergic effect of the antihistamines. No, so antihistamines are having anticholinergic effect. It will give dry mouth and lacrimation and all. So if these medications are given with MAO inhibitors, it will increase the anticholinergic effect. Again, with cholinesterase inhibitors, cholinesterase is responsible for the enzymes is responsible for the acetylcholine. Yeah, exactly, acetylcholine. So it cannot be given, especially like cholinesterase inhibitors as this one, donepezil, rivastigmine, and all this centrally acting anticholinergic effect. It should not be given because of the decreasing of the activity of cholinergic effect. And lastly, I have mentioned already this, which is phenoxyethanidate. They have withdrawn because of the cardiotoxicity effect. That's it. Any questions?
Come in the brand name of Allegra. Allegra 120, 180.